Video laryngoscopy. Is it the new gold standard? See the airway clearly. Video changes everything. What was once blind is now on screen. Improve first pass success. Higher success rates. Fewer attempts. Less trauma. Teach and learn faster. Everyone in the room sees what you see. Training becomes real time. Manage the difficult airway with confidence. Better glottic view. Better tube delivery. Better outcomes. Question the standard. Is direct laryngoscopy still enough? Or has video earned its place as the new default? The technology is here. The data is growing. The debate is real. Objectives. At the end of this presentation, participants should be able to 1. Define video laryngoscopy VL. Know exactly what it is and how it works. 2. Describe the history and evolution of video laryngoscopy. From early days to the technology we use today. 3. Identify the indications and contraindications for VL. Know when to use it and when not to. 4. Explain the different classifications of video laryngoscopes. Understand the types, blades, and how they differ. 5. Discuss the advantages and disadvantages of VL. Weigh the benefits against the limitations. 6. Describe its role in ICU, anesthesia, and emergency medicine. See where VL saves lives across specialties. 7. Outline nursing responsibilities before, during, and after the procedure. Prepare, assist, monitor, and follow through. 8. Compare VL with direct laryngoscopy and other airway devices. Know the differences in view, success, and technique. 9. Discuss current evidence and future trends in airway management. Stay ahead with data and what is coming next. 10. Evaluate whether video laryngoscopy should become the new gold standard for tracheal intubation. Make an informed judgment based on evidence and practice. Other names for video laryngoscopy. 1. Video-assisted laryngoscopy. 2. Indirect laryngoscopy. 3. Digital laryngoscopy. 4. Camera-assisted laryngoscopy. 5. Video-guided intubation. 6. Optical laryngoscopy. 7. Electronic laryngoscopy. Introduction by research findings. 1. Airway management is one of the most critical skills in anesthesia, emergency medicine, and intensive care. Master the airway. Master the patient. 2. Failed tracheal intubation remains a major cause of anesthesia morbidity and mortality. One missed airway can change everything. 3. Video laryngoscopy VL has transformed airway management by providing an indirect view of the glottis through a miniature camera mounted on the laryngoscope blade. See what you could not see before. Or, unlike direct laryngoscopy DL, VL does not require direct alignment of the oral, pharyngeal, and laryngeal axes. No more forced positioning. Better view with less force. 5. Numerous randomized controlled trials and systematic reviews that VL. 1. Improves glottic visualization. 2. Increases first pass intubation success. 3. Reduces failed intubation rates. 4. Lowers airway trauma. 5. Reduces cervical spine movement. 6. Improves teaching because the instructor and trainee share the same airway view. 6. International airway societies increasingly recommend early use of VL, especially for anticipated difficult airways. The evidence is clear. Use it early. Use it well. The myths. 1. Myth. Video laryngoscopy guarantees successful intubation. Fact. Excellent visualization does not always guarantee easy tube passage. 2. Myth. Direct laryngoscopy is obsolete. Fact. Direct laryngoscopy remains an essential backup skill. 3. Myth. VL is only for difficult airways. Fact: many centers now use VL routinely for all intubations. 4. Myth: anyone can intubate successfully using VL. Fact: and experience are still required. 5. Myth: video laryngoscopy completely eliminates complications. Fact: complications such as airway trauma, hypoxia, and failed intubation may still occur. Know the tool. Respect the skill. Organizational definition. 1. According to American Society of Anesthesiologists (ASA), video laryngoscopy is an indirect laryngoscopy technique using a camera-equipped laryngoscope blade to visualize the larynx during tracheal intubation. 2. According to Airway Society (DOS), an advanced airway device recommended for anticipated or encountered difficult tracheal intubation. 3. According to European Society of Anesthesiology and Intensive Care (ESAIC), a technology that improves visualization of the larynx and facilitates safer tracheal intubation. History. 1. 1854. Manuel Garcia first visualized the human larynx using mirrors. 2. 1941. Miller straight blade introduced. 3. 1943. Macintosh curved blade introduced. 4. 1999. Development of the first practical video laryngoscope. 5. 2001. GlideScope introduced commercially. 6. 2006. CMAC video laryngoscope introduced. 7. 2010. Present. Rapid worldwide adoption across anesthesia, ICU, and emergency medicine. 8. Today. VL is recommended in many difficult airway guidelines worldwide. Indications. Video laryngoscopy is indicated in 1. Predicted difficult airway. 2. Failed direct laryngoscopy. 3. Obesity. 4. Limited neck movement. 5. Cervical spine injury. 6. Trauma pace. 7. Airway tumors. 8. Obstructive sleep apnea. 9. ICU intubations. 10. COVID-19 patients. 11. Teaching and training. 12. Routine elective intubation. Classification. According to blade design. 1. Macintosh style blades. 1. Similar to conventional blades. Familiar curve and feel. Easy transition for anyone trained on direct laryngoscopy. 2. Can perform direct or video laryngoscopy. Versatile. Use it like a normal blade, or flip to the camera for a better view. 2. Hyperangulated blades. 1. Greater curvature. Steep 40 to 60 degree angle to look around the corner, without moving the neck much. 2. Ideal for difficult airways. Best when mouth opening or neck movement is limited. Gives you the best glottic view. 3. Channeled blades. 1. Built-in guide channel for the endotracheal tube. The tube rides in a slot. Less hand-eye coordination needed. Good for beginners or tight spaces. Classification. 1. According to reusability. 1. Reusable devices. Sterilized and used multiple times. Cost-effective long-term but need proper cleaning and maintenance. 2. Disposable devices. Single-use only. No cross-contamination risk. Perfect for emergencies, isolation cases, and field use. 2. According to display. 1. Integrated screen. Screen built into the handle. Compact and portable. Great for quick intubations and transport. 2. External monitor. Connects to a separate screen. Bigger view for teaching, and the whole team can see the airway. 3. Portable handheld devices. Battery-powered and lightweight. Ideal for pre-hospital, and ICU where you need to move fast. Clinical uses. Video laryngoscopy is used in 1. Routine anesthetic intubation. Standard cases in the OR. Gives a clearer view and reduces multiple attempts. 2. Difficult airway management. When direct laryngoscopy fails, the camera helps look around the corner for better visualization. 3. Awake intubation. Patient stays breathing and conscious. Video feedback helps guide the tube with minimal discomfort. 4. Rapid sequence induction. Emergency intubation where speed matters. Faster first pass success reduces aspiration risk. 5. Double lumen tube placement. For thoracic surgery, the screen helps confirm correct positioning in the bronchus. 6. Teaching residents. The whole team can see on the monitor. Makes training and feedback much easier. 7. Airway assessment. Evaluate vocal cords, swelling, tumors, or secretions before deciding on a management plan. 8. Trauma management. Useful with cervical spine precautions. Needs less movement to get a good view. 9. Bariatric surgery. Patients with obesity often have difficult airways. VL improves success rates. 10. End surgery. Helps visualize the airway during head and neck procedures where anatomy may be distorted. Use in ICU. Common ICU applications include 1. Acute respiratory failure. Urgent intubation needed. VL gives a better view when time is critical. 2. Septic shock. Patients are unstable. Faster, successful intubation reduces the risk of crash airway. 3. ARDS. Lungs are very stiff and oxygen is low. First pass success helps avoid prolonged hypoxia. 4. COVID-19 respiratory failure. Reduces aerosol exposure to staff. Also helps swollen, difficult airways. 5. Difficult airway. ICU patients often have edema, secretions, or limited mouth opening. VL improves visualization. 6. Re-intubation. After extubation failure, airways are usually more swollen and harder, so VL helps. 7. Airway exchange procedures. Swapping tubes safely. The camera guides placement to avoid losing the airway. 8. Mechanically ventilated patients. For tube changes or bronchoscopy-assisted intubation while keeping oxygenation up. Benefits. 1. Better first pass success. More likely to get the tube in on the first try. Less trauma to the airway. 2. Reduced hypoxia. Fewer attempts means less time without oxygen. Critical for ICU patients. 3. Reduced complications. Less dental trauma, bleeding, and esophageal intubation compared to direct laryngoscopy. 4. Less cervical movement. Important for trauma or unstable neck patients. You can intubate with minimal head-neck motion. Use in anesthesia. 1. Elective surgery. Planned OR cases. VL provides a clear view and reduces multiple attempts, making induction smoother. 2. Difficult airway. Anticipated or unexpected hard intubations. The camera helps visualize around the corner when direct laryngoscopy fails. 3. Bariatric surgery. Patients with obesity often have excess soft tissue. VL improves glottic view and first pass success. 4. Obstetric anesthesia. Pregnant patients have airway edema and higher aspiration risk. Quick, successful intubation is critical. 5. Cardiac surgery. Hemodynamically unstable patients. Faster intubation with less stimulation helps maintain stability. 6. Thoracic surgery. Often needs double lumen tubes. VL helps confirm correct bronchial placement on screen. 7. Neurosurgery. Needs minimal neck movement to protect the spine. VL allows intubation with less head extension. 8. Pediatric anesthesia. Small airways and unique anatomy. The magnified view helps with precise tube placement in children. 9. End surgery. Airway anatomy may be distorted by tumors or surgery. VL gives better visualization of distorted structures. Use in emergencies. 1. Trauma. Patients are unstable and may have blood or vomit in the airway. VL gives a better view with less cleanup time. 2. Cardiac arrest. Every second counts. Faster first pass intubation means less interruption to chest compressions. 3. Burns. Facial and airway swelling can make intubation hard. VL helps visualize before edema worsens. 4. Airway obstruction. From swelling, infection, or secretions. The camera lets you see past obstructions to play tube. 5. Cervical spine injury. Needs minimal neck movement. VL allows intubation with inline stabilization to protect the spine. 6. Maxillofacial trauma. Broken jaw, bleeding, and distorted anatomy. VL improves visualization. Direct view is poor. 7. Foreign body aspiration. Helps locate and bypass the object. Also useful for guiding tools to remove it. 8. Failed airway rescue. When bag mask or direct laryngoscopy fails. VL is a key backup to secure the airway quickly. Nursing management. Before intubation. 1. Prepare video laryngoscope. Get the device ready and clean. Confirm you have the right type for the case. 2. Check battery level. Make sure it's fully charged. A dead battery during an emergency wastes critical time. 3. Ensure monitor functions. Test that the screen and camera work. The whole team needs to see the airway clearly. 4. Select appropriate blade. Choose Macintosh, hyperangulated, or channeled based on patient airway and operator preference. 5. Prepare ET tube and stylet. Have the correct size tube ready with a stylet. Shape it to match the blade curve. 6. Prepare suction. Turn on and test suction. Blood, vomit, or secretions can block the view instantly. 7. Administer oxygen. Pre-oxygenate the patient. Builds an oxygen reserve to prevent desaturation during intubation. 8. Apply monitoring. Attach SpO2, BP, and ECG. Watch vitals closely during induction and intubation. 9. Assist positioning. Place patient in sniffing position, or keep neck neutral for trauma. Good position equals better view. Nursing management. During intubation. 1. Hand equipment to clinician. Pass the laryngoscope, tube, and other tools smoothly. Keeps the process fast and organized. 2. Monitor SpO2, ECG, BP. Watch vitals continuously. Alert the team immediately if oxygen or blood pressure drops. 3. Suction secretions if required. Clear blood, vomit, or secretions. A clean view is key for successful tube placement. 4. Assist with tube advancement. Guide ET tube as directed. Help angle it to follow the blade and enter the glottis. 5. Confirm cuff inflation. Inflate the cuff to seal the airway. Prevents leaks and aspiration of stomach contents. 6. Observe patient response. Watch for coughing, deterioration, or hemodynamic changes. Report problems right away. After intubation. 1. Confirm ET tube placement. Use capnography, chest X-ray, and auscultation. Must verify tube is in the trachea, not esophagus. 2. Secure tube. Tape or tie the tube properly. Prevents accidental extubation or movement. 3. Document procedure. Record blade type, attempts, tube size, depth, and who performed it. Important for legal and clinical records. 4. Clean reusable equipment. Decontaminate and sterilize reusable blades and handles per protocol to prevent infection. 5. Dispose of single-use blades. Throw away disposable parts in proper sharps biohazard bins. Reduces cross-contamination risk. 6. Monitor patient continuously. Keep checking vitals, tube position, and ventilation. Early detection of complications saves lives. Contraindications. There are no absolute contraindications, but relative contraindications include 1. Severe mouth opening restriction. If you can't fit the blade in, you can't get a view. Trismus or jaw trauma makes insertion impossible. 2. Massive airway bleeding. Blood covers the camera lens immediately. You lose visualization and risk aspiration. 3. Copious secretions. Too much saliva, pus, or fluid fogs the camera and blocks the view even with suction. 4. Active vomiting. High risk of aspiration. The airway needs to be cleared and protected first before any intubation attempt. 5. Extensive facial trauma preventing blade insertion. Broken jaw, swelling, or deformity blocks the path for the blade to reach the airway. 6. Severe airway contamination. Food, debris, or chemicals in the airway obscure the camera and increase infection, aspiration risk. Precautions. 1. Always prepare a backup airway plan. Have a plan B and C ready. If VL fails, you need bag mask, bougie, or surgical airway immediately. 2. Ensure battery is fully charged. A dead device mid-procedure is dangerous. Check power before starting any case. 3. Clean camera lens. Smudges or secretions blur the view. A clear lens gives the best glottic visualization. 4. Have suction immediately available. Blood and secretions can block the view in seconds. Suction keeps the airway clear. 5. Use an appropriately shaped stylet. Match the stylet curve to the blade. Helps guide the tube into the glottis smoothly. 6. Avoid excessive force. Gentle technique prevents dental, lip, and airway trauma. The camera do the work. 7. Confirm tube placement with capnography. Waveform CO2 is the gold standard. Proves the tube is in the trachea, not the esophagus. 8. Be prepared for failed intubation. Stay calm and switch to backup plan fast. Every second of hypoxia increases risk to the patient. Advantages. 1. Superior glottic visualization. The camera gives a wide, magnified view of the vocal cords. Easier to see even with poor anatomy. 2. Higher first pass success. More likely to get the tube in on the first try. Reduce time without oxygen. 3. Better success in difficult airways. Works well with swelling, obesity, or limited mouth opening where direct laryngoscopy fails. 4. Reduced cervical spine movement. You don't need to extend the neck much. Safer for suspected spine injury. 5. Less dental trauma. Less force needed to lift the tongue. Fewer broken teeth and lip injuries. 6. Improved teaching. Trainees can watch the screen and learn technique in real time from the operator's view. 7. Shared air view. The whole team sees the same screen. Helps with coaching, timing, and confirming placement. 8. Image recording. You can record video or take pictures. Useful for documentation, audit, and review. 9. Better patient safety. For attempts and less hypoxia. Overall risk of complications goes down. 10. Reduced airway manipulation. Less pushing, pulling, and force inside the mouth and throat. Less tissue trauma overall. Disadvantages. 1. Expensive equipment. Video laryngoscopes and disposable blades cost a lot. Not every hospital or department can afford them. 2. Camera obscured by blood. Even a small amount of blood on the lens blocks the view completely. Lose the main advantage instantly. 3. Secretions reduce visibility. Saliva, vomit, or mucus fog and smear the camera. You need constant suction to keep the view clear. 4. Lens fogging. Warm humid air from the patient can fog the cold lens. Reduce visibility at the start of the case. 5. Battery dependence. If the battery dies or isn't charged, the device is useless. Always need to check power first. 6. Learning curve. Seeing on screen is different from direct view. Staff need practiced tube delivery and hand-eye coordination. 7. Difficult tube advancement despite excellent view. Sometimes you can see the cords perfectly but still struggle to get the tube through. The angle can be tricky. 8. Equipment malfunction. Screens can freeze, cable can fail, or blades can be defective. Always need a backup plan ready. Clinical considerations. 1. Select the correct blade size. Too big or too small makes visualization hard. Match the blade to patient age and mouth opening. 2. Use a rigid stylet for hyperangulated blades. The sharp curve needs a shaped stylet to guide tube. A floppy tube won't follow the view. 3. Optimize patient positioning. Sniffing position, or neutral neck for trauma. Good position lines up the airway for easier intubation. 4. Ensure adequate pre-oxygenation. Give 100% oxygen. Builds a reserve so patient doesn't desaturate during attempts. 5. Minimize intubation attempts. Multiple tries cause trauma and hypoxia. If it fails, switch to backup plan early. 6. Always have rescue airway equipment available. Bougie, supraglottic airway, and surgical kit ready. Be prepared if VL fails. 7. Confirm tube placement using waveform capnography. CO2 waveform proves the tube is in the trachea. This is the gold standard, not just listening to breath sounds. 8. Consider operator experience. Skill matters. Less experienced operators may need help or a different blade type for success. Comparison with other airway devices. 1. View. Direct laryngoscopy. Direct video laryngoscopy. Camera-assisted flexible fiberoptic scope. Fiberoptic. Explanation. Direct needs line of sight. Video uses a camera on the blade. Fiberoptic uses a scope through the airway. 2. Difficult airway. Direct laryngoscopy. Moderate video laryngoscopy. Excellent flexible fiberoptic scope. Excellent. Explanation. Video and fiber optic handle swollen or hidden is better than direct. 3. Cervical movement. Direct laryngoscopy. Greater video laryngoscopy. Less flexible fiberoptic scope. Minimal. Explanation. Direct needs more head and neck extension. Video and fiber optic need much. Good for trauma. 4. Teaching. Direct laryngoscopy. Poor video laryngoscopy. Excellent flexible fiberoptic scope. Moderate. Explanation. With video everyone can see the screen. Direct only the operator sees. Fiberoptic is harder to share. 5. Cost. Direct laryngoscopy. Low video laryngoscopy. High flexible fiberoptic scope. Very high. Explanation. Direct laryngoscope is cheapest. Video devices cost more. Fiberoptic scopes are the most expensive. 6. Learning curve. Direct laryngoscopy. Moderate video laryngoscopy. Moderate flexible fiberoptic scope. Long. Explanation. Direct and video take moderate practice. Fiberoptic needs extensive training to master. 7. Routine use. Direct laryngoscopy. Excellent video laryngoscopy. Excellent flexible fiberoptic scope. Limited. Explanation. Direct and video are used daily for normal cases. Fiberoptic is mostly for or difficult cases. Additional information. Common video laryngoscopes include 1. GlideScope. One of the most widely used hyperangulated video laryngoscopes. Good for difficult airways. 2. CMAC. Looks like a direct laryngoscope but with a camera. Can be used for direct or video view. 3. McGrath Mac. Portable, battery-powered, and often disposable blade. Good for emergencies. 4. King Vision. Compact handheld device with disposable blades. Popular in EMS and ICU. 5. Track. Channeled blade that guides the tube. No stylet needed with this one. 6. Pentax Oz. Has a built-in channel to deliver the tube. Helps with tube control. 7. Laryngoscope. Cost-effective video laryngoscope used in many hospitals. Provides clear camera view. Essential accessories. 8. Stylet. Shapes the endotracheal tube to match the blade curve. Helps get the tube into the glottis. 9. Bougie. Thin flexible introducer. Used to find the trachea first, then railroad tube over it. 10. Suction catheter. Clears blood, saliva, and secretions. Keeps the camera lens and airway clear. 11. Oxygen source. For pre-oxygenation and apneic oxygenation. Buys you time during intubation attempts. 12. Capnography. Measures CO2 waveform. Confirms the tube is in the trachea, not the esophagus. 13. Backup airway equipment. Includes supraglottic airways and surgical airway kit. Plan B if video laryngoscopy fails. Current trends. 1. Routine first-line use for intubation. Many hospitals now use video laryngoscopy as the first choice, not just for difficult cases. It increases first-pass success. 2. Portable handheld video laryngoscopes. Devices are getting smaller and battery-powered. Easy to carry to wards, and field use. 3. Disposable blades reducing infection risk. Single-use blades avoid cross-contamination. Also solves cleaning and sterilization problems. 4. IAS airway recognition. New software can highlight the vocal cords and guide placement. Helps trainees and in stressful cases. 5. Digital recording for education. The video can be recorded and replayed. Used for teaching, audit, and skill review. 6. Mentoring during difficult airway management. Experts can watch the screen live and guide you remotely. Useful in low-resource or rural areas. 7. Wider use in pre-hospital medicine. Ambulances and emergency teams are adopting video laryngoscopes. Improves airways outside the hospital. Research. Current evidence demonstrates. 1. Improved first-pass success compared with direct laryngoscopy. Studies show you get the tube in on the first try more often. This cuts down hypoxia and complications. 2. Better Cormac-Lehane laryngeal views. The camera gives a clearer grade 1 or 2 view of the vocal cords, even when direct view is poor. 3. Reduced failed intubation. Fewer cases where you cannot get the tube in. Especially useful in difficult airway situations. 4. Reduced esophageal intubation. Better visualization means fewer tubes going into the food pipe by mistake. Improves patient safety. 5. Less airway trauma. Less force and fewer attempts needed. Results in less lip, dental, and throat injury. 6. Better outcomes in obese and critically ill patients. These groups are high risk. Video laryngoscopy gives faster and safer intubation for them. 7. Significant benefit for novice clinicians. Trainees learn faster and succeed more with video. The screen helps them what to do. 8. Strong recommendation in modern difficult airway guidelines. Major airway societies now recommend video laryngoscopy as first line for anticipated difficult airways. Research. Ongoing research focuses on 1. Artificial intelligence integration. AI can detect vocal cords and predict difficult airways in real time. Helps guide less experienced users. 2. Robotic-assisted airway management. Ropes may help position the blade and advance the tube. Aims to make intubation more precise and consistent. 3. Smart airway devices. Devices with sensors that give feedback on pressure, depth, and placement. Reduces trauma and errors. 4. Low-cost portable video laryngoscopes. Research into cheaper, battery devices for clinics and low-resource settings. Makes the tech more accessible. 5. Augmented reality airway navigation. AR overlays can project airway anatomy on the patient. Helps the operator see the path for the tube. Patient education. Patients should be informed that 1. Video laryngoscopy is a safe method of inserting a breathing tube. It uses a camera to help place the tube. This makes the process more controlled and reliable. 2. It improves visualization of the airway. The doctor can see the vocal cords on a screen. This gives a clearer view than with direct laryngoscopy. 3. It may reduce complications during difficult intubation. Fewer attempts are usually needed. This lowers the risk of injury and low oxygen. 4. The procedure is performed under appropriate anesthesia or sedation when indicated. You will be asleep or sedated so you don't feel discomfort during tube placement. 5. Minor sore throat may occur after intubation. A bit of throat irritation is common and goes away in a day or two. It's normal after having a tube. 6. Serious complications are uncommon. Major problems are rare with modern equipment and trained staff. Safety is the top priority. 7. The anesthesia team is trained in advanced airway management and has backup plans if difficulties arise. The team is prepared with other devices and techniques. You are in experienced hands if the airway is challenging. Conclusion. 1. Video laryngoscopy has revolutionized airway management by improving visualization of the larynx, increasing first-pass intubation success, and enhancing patient safety. The camera gives a better view, so the tube goes in faster on the first try with fewer risks. 2. It has become an indispensable tool in anesthesia, emergency medicine, and intensive care. It's now used routinely in ORs, ERs, and ICUs because it works well in both routine and emergency cases. 3. Current international guidelines increasingly recommend its early use, particularly for anticipated difficult airways. Major airway societies say to reach for video first when you expect a hard intubation. 4. Although direct laryngoscopy remains an essential skill and backup technique, the growing of evidence supports video laryngoscopy as the preferred first-line approach in many clinical settings. Doctors still need to know direct, but research shows video is better as the first choice most of the time. 5. As technology continues to evolve, video laryngoscopy is poised to become the standard of care for airway management in modern clinical practice. With AI, portable devices, and better design, it will likely be the default tool for intubation going forward. Take-home tips. 1. Always perform a thorough airway assessment before intubation. Check mouth opening, neck movement, and airway anatomy first. Helps predict if it will be difficult. 2. Video laryngoscopy improves glottic visualization but does not eliminate difficult intubation. You can see better, but tube delivery can still be hard. Plan for challenges. 3. Use an appropriate blade and style it for optimal tube delivery. Matching the curve of the blade and tube makes passing the tube easier. 4. Maintain proficiency in both video and direct laryngoscopy. Devices can fail or not be available. You need both skills as backup. 5. Always prepare a backup airway strategy. Have a supraglottic airway or surgical kit ready before you start. Plan B saves lives. 6. Confirm tracheal tube placement with continuous waveform capnography. CO2 waveform is the gold standard to prove the tube is in the trachea, not the esophagus. 7. Minimize repeated intubation attempts to reduce complications. Too many tries cause trauma and oxygen. Stop, oxygenate, and change strategy if needed. 8. Regular training and simulation improve success and patient safety. Practice on mannequins keeps skills sharp for real emergencies. 9. Early use of video laryngoscopy is recommended for anticipating difficult airways. Don't wait to fail with direct first. Start with video when risk is high. 10. Technology enhances airway management, but clinical judgment remains paramount. The machine helps, but your decision-making and assessment are what keep the patient safe. Professional quote. The best airway device is the one that secures the airway safely in the hands of a skilled clinician. However, in modern practice, video laryngoscopy is increasingly becoming the standard for safe, effective, and evidence-based tracheal intubation. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.